Welcome, everyone. My name is Dr. Tim Brown. I'm the host of Pharmcast for the Community for the University of Georgia's College of Pharmacy. And today I have two guests on board. The first is Dr. Trisha Branan. Dr. Branan is actually with the University of Georgia's College of Pharmacy as well as a clinical associate professor. She's also board certified in critical care and the current president of the Georgia Society of Health System Pharmacists. I also have Dr. Susan Smith on board as well, who's also board certified both in pharmacotherapy and critical care. She's a clinical assistant professor here at the University of Georgia College of Pharmacy. Does a great deal of research on shock and hemodynamics. What you may have heard me say in both of these introductions, which is a common thread, they both work in medical, surgical, critical care units, or what many people refer to as ICUs. Welcome, ladies. How are you?
I'm good. Thanks
for having us.
No problem. Thanks for coming on board. I know you're busy with everything going on, so I appreciate you being here. I think it may surprise some of our listeners to realize that pharmacists who are also professors in colleges of pharmacy also practice in hospital and other settings, but in particular, I mentioned critical care and ICU. We know about physicians and nurses, but tell me a bit about what it's like to be in the hospital in your role. As pharmacists, what do you guys do here in Athens for one of the local health systems?
Yeah, well, I think what you'll find that what most clinical pharmacists do, but especially those of us that work in critical care, one of the things that's sort of interesting about critical care is that because of the complexity of these patients, it really takes a really all hands-on approach with a lot of different healthcare disciplines working together to care for a patient. So every day when either one of us is on service at our practice site, we will look at patients, review each of the patients that are in our ICU, and then round with our team that's led by our physician, but also includes a lot of the other health disciplines to take care of these patients and provide recommendations specifically related to their medication therapies every day.
So Dr. Smith, when you're rounding with this team, you're rounding with physicians and nurses and other healthcare professionals, Dr. Branan said. Do you recommend medications? Do you actually sort of tell the folks, this is what we should use for this patient today of whatever's going wrong?
Yeah, absolutely. So I think one of the real benefits of working in an interprofessional team is that we can each provide expertise in our area. So in the ICU, we're really viewed as the medication experts. So we provide recommendations to the team in optimal drug therapy, appropriate dosing. In critical care in particular, we have to think about routes of administration that are available for the patient and for the medications, monitoring drug levels, as well as laboratory values that are related to different medications. So we're really serving as the medication experts for the team and providing really patient-specific recommendations to optimize their drug therapy in the ICU.
So you're helping folks make that final decision, if not making it yourself. So I have to ask, with everything that's been going on with COVID-19 and the worries that people have, and a lot of the patients have been admitted to the ICU or the critical care units, what are you seeing there as critical care pharmacists? Dr. Branan, I'll let you address that one first, but what have you seen as a difference versus in the ICUs versus maybe before COVID-19? What's going on to either prepare for this or care for the patients that we've seen in and around this area?
I think one of the biggest things that we've seen is it sort of kind of has ramped up a lot of the information and the changes that are coming almost even on a daily, if not hourly updates. So it really is requiring, a lot of us that are practicing in this setting of really staying, abreast as to what we can learn from these areas that are a little ahead of us in terms of the number of patients or providing medical services related to these patients, and being able to learn kind of what they have experienced and how we should, best optimize our care for these patients in a really just rapidly changing environment.
Dr. Smith, I know that you were actually on rounds today and in the hospital. What are you seeing as the ramp up? Are we seeing drug shortages? Are we able to get what we need to treat the folks today?
Yeah, I think there are a few things that different critical care units have been facing nationally. And so drug shortage is one of those. So shortages, not necessarily just in the medications that we're seeing on the news of potential treatments for COVID-19, but also shortages in some of our just routine critical care medications because there's been a greater need for them across the country. So as the pharmacist in the ICU, we are thinking about alternative therapies. We're trying to plan so that we don't run into problems with the drug shortage, but instead already have secondary and tertiary options in place that will work effectively for our patients. So we've definitely been staying busy thinking about alternative therapies and different ways that we can give medications to our patients in the ICU.
Let's go back. That all sounds really great. But if I'm sitting at home and I don't work in medicine whatsoever, what is alternative therapies? Do you mean that like we're missing antibiotics? Or are we missing drugs that help us stay asleep? Sort of what are you working around? I think is the big topics this day and age that people are hearing on the news. I mean, hydroxychloroquine is sort of taking over, but you're sort of telling us something new here, that there are other drugs that we may not have in abundance that we use to help people as well. And you're working around that, correct?
Sure. Yeah. So one example would be medications that we use for sedation. So we've heard a lot about ventilators, and a lot of times when patients are on the ventilator, we need to provide medications for sedation so they don't become agitated and uncomfortable with the ventilator.
So sedation to help them sleep or to be calm, right?
Exactly.
Sort of keep them at the area. Yeah, I really want people to understand that everybody got sort of caught up on this hydroxychloroquine sort of thing going on. And you're telling me that you've been working really hard to make sure you maintain medications just so people can actually get good care, like be on that ventilator that everybody's been talking about, right?
Exactly. Yeah.
I understand. So I guess the question I've been asking is, so if a patient gets admitted to the ICU, in the past, I know when I worked in primary care and we rounded in the ICU, people were allowed to come in and visit, right? If I had a grandparent there, you'd have somebody holding their hand. I would imagine hospitals have really been strict on cutting down the visitors that come in. Is that true, Dr. Branan?
Yeah, it's really important just with everything related to the COVID-19 virus is trying to minimize overall exposure for our patients, caregivers, but also with our healthcare teams and our hospital workers. So there has been a need to really decrease the amount of visitation and just kind of the overall traffic that's moving throughout the hospital. Which is very, difficult in an already difficult situation. So now you have patients who are admitted, to the ICU who are not allowed to have visitors. It's really hard to kind of convey information to families and other caregivers if you're not able to see, your loved one in this environment. So it's really created a challenge, and it also can be, kind of a scary situation for these patients as well. When they're in the ICU and they're, so sick and sometimes, on the ventilator for weeks at a time or in the ICU for weeks at a time and kind of being, cut off from their loved ones. Not only that, you have a lot of, the healthcare workers that are requiring, to wear that protective equipment that, really looks like those hazmat suits. So it can be a really scary time for these patients when they're kind of alone in these settings. So it also creates another challenge, for those of us on the healthcare team to kind of see our patients experiencing that and know that they're having difficulties with that. So it's kind of opened a window too, where we have some, new strategies or things that we have to think about. Or are there ways that we can help calm these patients, kind of keep them comfortable, let them know what's going on? Are there ways, different ways and unique ways we can connect them with, their families and other loved ones, through we've had examples of, setting up either FaceTime or Zoom calls with family members, video conference.
Oh, wow. So someone's using their phone or some sort of technology, and so the patient's lying in the bed in the critical care unit, and they're kind of FaceTiming with their family so they can communicate and see each other. Our loved ones, I guess. I mean, thinking about spouses who have been separated as well as kids and parents. So you've seen people do that? Have you done that as well?
Yeah, so not personally, because we're trying to decrease the overall traffic into the room. So like at least at our institution, the pharmacists are not entering the room right now, so we can help minimize some of our use of the protective equipment for those healthcare professionals who are really needed at the bedside. But yeah, so, using technology to connect families. So I've seen some examples where some of the healthcare providers are putting pictures of themselves taped to the outside of their protective suits so that people can see kind of what they look like underneath all of those, all of that equipment, just so it gives a little bit of more of a comfort to some of these patients who are really, undergoing some really difficult circumstances.
Sure. I think it's impressive that, as you point out, those big old suits, you can't really tell who's under that hood and who's there. I love that idea of the fact there's a taped picture of that person there, kind of like so they know exactly who's taking care of them. That has to be nice for the patients. Tell me a bit about this delirium that we're hearing. I heard this term the other day in the news, ICU delirium or critical care delirium, because we've been talking a lot about mental health of people who've been stuck at home, right? I mean, let's face reality, I'm about to go crazy here. I've been stuck at my home now for 2 weeks, sort of working, doing various things. What's it like to be in the ICU as a patient and not really have that connection? Dr. Smith, I know you've been working with patients, and especially today, I think you were at service as well. Tell me a bit about, does mental health play a huge role in this? I'm assuming it does.
Yeah, I'm so glad you asked this question because I think ICU delirium is something that's really important for us to think about right now, and it really plays hand in hand into what Dr. Branan was just talking about. So you can imagine that if you're a patient in the ICU, you're very sick if you're requiring critical care. You might be intubated, so have a breathing tube that's kind of doing the work for your lungs for you. You might be receiving sedative medications like we mentioned earlier that are helping with agitation and helping you to sleep. And so you have lots of things that are going on that are not normal, not part of your normal routine. You have nurses and doctors coming in at all different hours of the night to monitor your vital signs, to give medications, to do other parts of their care to take care of you. But all of these things prevent normal sleep and wake patterns, prevent just kind of normal daily functioning that all of us are doing outside of the ICU. And all of those things can lead to ICU delirium, which can happen in an agitated state. So patients are perhaps even, seeing hallucinations or have a kind of dissociated state.
All right, go back. You got to help me now. Delirium, they're just not thinking correctly, but you said hallucinations. That's when you see things that aren't there, right?
It is. So ICU delirium can take many different forms. And so one form of that is even as far as having hallucinations. You can imagine all these different things going on to patients in the ICU. They might have memories of them that are different from the reality. So that can be in the form of hallucinations, or just interpreting, not understanding what's going on and interpreting things differently. When we have family at the bedside, they can be a really key part of the patient's care in terms of reorienting them to what is truly happening, and providing just some calm and some familiarity in a really scary and uncomfortable environment. So not having the family members at the bedside, I think, really puts these patients at even greater risk than usual of acquiring ICU delirium, which can actually lead to even long-term consequences after the ICU stay.
I see. So in other words, ICU delirium is basically not knowing where you are, kind of acting out, maybe being depressed, but also, I guess, just a little confused, right? Because everything is going on and there's nobody there to look normal. Your spouse isn't there, your kids aren't there, you're not sleeping in your own bedroom, your routine is way off, and you may be sleeping during the day and awake at night or whenever the drug wears off. And wow, that's a lot that's going on. I can't imagine all that. And then we've sort of cut off their families from them because of worry of the infections. So the staff in the ICU must be playing a really pivotal or amazing role in, if you will, calming that down and I guess making people feel better. Is that fair to say that's been one of the common themes among all the staff in the ICU? Physicians, nurses, pharmacists, dietitians, of course, those that work there in terms of coming in to clean the room and the janitorial. They really are a family for these patients at this point in time, aren't they?
They are, and I think it's been really great to see just the compassion come through. And like you mentioned, every single person involved in the care, it's not just the nurses and doctors, they obviously have essential roles, but every team member, the janitorial staff, the food workers providing meals, everyone's really just displaying a lot of compassion for these patients, and really are coming together as a family and a support system for them, which is really heartwarming to see.
That's nice to see. I just saw a campaign by one of the local home builders, and they're saying, make anything at your home out of any supplies you have to thank workers out there. And I think it's important for people to realize that while physicians and nurses are very important, there are a lot of people on that team as well. So if you're making your signs and thinking outside the box, everybody, sort of think of everybody out there that needs a pat on the back, because that's pretty impressive. I guess the other thing I have to worry about, Dr. Branan, I know you personally, and I know you have a family, and I know you go to work and come home. How are you protecting yourself from also everything going on with COVID-19 and also going home and trying to have, excuse this term, a normal life? Teaching your kids, being with your spouse, those kinds of things. What are you guys doing to keep yourself safe?
Yeah, I think that's a really, good question. And I think that's a lot of the things that I've had a lot of conversation with a lot of my friends and colleagues, that work, in the healthcare and the hospital environment, especially those of us who are, in these units that are caring for these patients. It's something that's sort of different about the coronavirus compared to, our other like normal ICU type infectious disease processes is, we haven't always had that level of concern about what we may personally, become infected with, or what we may personally bring home to our families and loved ones. So it's kind of presented a new layer of just thought about what kind of what you're doing when you're leaving work. So I know, like, especially for me and my husband, who also works at the hospital as well, we're trying to take as many precautions as we can to protect our families so that we're able to continue to care for patients while also, keeping our children safe, especially. So, like taking our shoes off at home. Taking our shoes off before we come into our house, changing clothes before we come into the house, things, going straight into the washer, showering as soon as you kind of enter the door before we interact with our family, are just some of the things that we're kind of thinking about and being, something we've always thought about in the ICU setting, especially, but I think even more so now, just making sure that we're, extra cognizant of what we're doing.
Got it. Dr. Smith, Dr. Braden, both answered this question, but I know this, I've heard healthcare workers talk about the dangers, right? They worry about themselves, they worry about their families. So why do you get up and go to work every day then? I know that sounds like a kind of a trite question because I know what you've trained to do and I know you love what you do, but you're making decisions that impact not only you, but those around you. So why do you feel that pharmacists should be in the ICU every day? What are they bringing to the table that no one else can?
Yeah, I think that pharmacists are really essential members of the team in any setting in the ICU, and now more than ever with some issues that we're dealing with drug shortages, like I mentioned, with seeing different adverse effects to some of the medications sometimes with these patients. So I think now more than ever, there's really a critical need for pharmacists to be involved in the care of these patients. I know personally it's very challenging, like Dr. Branan was mentioning, that we do need to, all healthcare providers right now need to take precautions to make sure you're caring for yourself and your family. But I know this is kind of what I trained to do, is to care for critically ill patients. And so I would feel like I was doing a disservice to my training and to my patients and to the team if I wasn't there in the unit helping to care for these patients and provide just optimal medication management for them.
I understand. Dr. Branan, anything to add?
Yeah, the thing I would add, and I totally echo everything that Dr. Smith, has mentioned. I think that I've worked in the ICU setting for almost 15 years now. And, it is, something that you think about, in terms of for yourself and the safety of your family. But, at the end of the day, I think we both feel pretty strongly that this is what I trained for. This is, my area of expertise. If there is, anything that I can do that would help improve the care of these patients or help support, my healthcare team, then I think it's important that, we're still providing that. Something that I personally, have found really interesting kind of in this time is that we are utilizing a lot of therapies that I haven't utilized either ever, or things that I did a long time ago when I was first coming into practice in the ICU that we just haven't done in a really long time, or we've had to kind of go back to just related to some of these other alternative therapies we're sort of having to come up with. So I think, having people that are trained in this area, especially that provide this expertise. I know that our nursing and physician colleagues are, very appreciative and daily, thank us for, being a part of the team and kind of helping them manage through this pandemic. As we kind of sort of mentioned, with the rapid change of information that's available, that analogy of like many hands make a lighter load, I think is more important and obvious as ever. So I think just having all of these people kind of evaluating this data and coming together to make a decision together, I know makes us all feel better.
I see that. I know you both are very, excuse the term, married to your jobs and your careers. I know you've chosen your path in critical care as a pharmacist because it's where your heart is and continues to be. So I want to ask, as we come to an end of the podcast today, can you do me a favor? If I or any of my family members were admitted to the ICU, give me 3 pearls of wisdom or 3 ideas that you think that I should know or a member of my family should know if this happens to me. Dr. Smith, I'll begin with you.
Sure. I would say, number 1, to just know that there is a large team of professionals who are experts in their individual fields that all have your family member best interest in mind and are all working together really cohesively to care for your family member. So
a big old team working together, right?
It is. And nice. I think although you may not be able to be there with your family member, it just hopefully could provide some peace of mind to know that there are a lot of people there that are putting that person first and providing the best care.
Nice. Dr. Branan, do you have one?
Yeah, I would say, also, I totally agree with what Dr. Smith has mentioned, but I would also say, don't be scared to ask questions and express your concerns and feelings over kind of what your loved one may be experiencing, but also what you as a, caregiver or a family member may experience. Some of the things that we've mentioned, like with ICU delirium, or even we haven't had really time to kind of touch on it, but like post-intensive care syndrome affects not only patients, but also, family members and loved ones. So I think it's really important to ask questions if you're confused or you're unsure what's going on, or if you just have concerns, or if you are having a hard time kind of also managing what's happening to your loved one, to make sure that you express that and are also caring for yourself in this time as well.
I think you bring up a good point. Even in your discussion, if you said what was it again? Post what?
Post-intensive care syndrome.
See, if that were my mother, she'd be like, what the heck are you talking about? So if you don't understand the words we're using, ask questions about them so people know. That's a really good point. Ask questions, take care of yourself, and don't be afraid to say, I don't get it. Explain that to me again. Because I think that's really important, because we all sort of get caught up in the medical jargon. And I think it's really important for family members and patients to say, it's okay. We expect you to ask us questions. That's good. I like that one. And I need one more pearl. Who's going to give it to me? Dr. Smith or Dr. Branan? Who has it?
So I'll provide one more. It's actually a resource that I would refer you to. So I would encourage anyone with a loved one that's going through this, or just if you're interested, to look at the website ICUdelirium.org and click on the section for patients and families. And this provides just a wealth of information about what ICU delirium is, as well as the post-intensive care syndrome that Dr. Branan mentioned. But it also provides a lot of tips and guidance for things that you can do to help your loved one through their ICU stay.
Wonderful. And that's ICU, spell delirium for me.
ICU Delirium, so DELIRIU.
And then ICU, just like it sounds, I, a C, and a U with delirium. And that'll get them at least in a Google search. That's a great idea. It also gives people a resource they can look at and read a bit that's written maybe on a level that we can all understand versus all that jargon out there.
Yeah.
Dr. Branan, Dr. Smith, thank you so much. And I want to say thank you also for being on the front lines and taking care of our community and being a large part of the way we're battling this particular infection, but also what you do day to day. Even without this infection, you go to work every day and save people's lives. And for that, we're grateful. Thank you so much. Both of you are wonderful. And thanks for joining me. I really appreciate it.
Thank you. Appreciate it.